the secretion of the gastric juice, and it will also enhance the pyloric pump. So two factors within the stomach, the presence of the food and the hormone gastrin. Now, as I said, more important control is from the duodenum itself, because it's involved in the process of digestion, or the first part of the small intestine involved in the digestion and absorption. So it is the boss control. And from within the duodenum, as I said, there is two mechanisms: by inhibiting the pyloric pump and increasing the tone of the pyloric sphincter muscle. The stimuli for duodenal control factors are distension of the duodenum. Once the duodenum is distended, it will send signals back to the stomach: please slow your emptying or stop your emptying, whatever. The other most important thing is the acidity of the chyme. The acidity of the chyme is a strong stimulator for the duodenal mucosa. So once there is too much acid in the duodenum, this will be activated within very quick time, within like 30 seconds, to inhibit the gastric emptying. And this will also ask the pancreas for a secretion of its products to neutralize the acid within the duodenum. This is a very strong stimulating factor. The other factors is undigested protein or fat products within the duodenum, too hypertonic or too hypotonic chyme, also irritation of the duodenal mucosa. Now, the emptying is, as I said, there is enterogastric reflexes from this intestine to the stomach, asking it to inhibit the gastric emptying. And this is mediated by two pathways, either through the intrinsic enteric nervous system of the gut itself, and this is stimulated directly by distension from the stomach or the duodenum. Also through extrinsic verbs that going into the prevertebral sympathetic ganglia, then coming back through inhibitory nerve fibers to the stomach, inhibiting the emptying, inhibiting the bump, and increasing the tone of the sphincter, or also from the vagus nerve to the brainstem, and this will inhibit the signals transmitted to the stomach through the vaga. Now, other than the neuronal regulation, زي في عندنا كمان hormonal factor, which is very important in the regulation of gastric emptying, and these mainly, as I said, stimulated or secreted by the duodenum. The first one is the cholecystokinin hormone, which we talked about it in the last lecture, and this is secreted from the duodenum, which this hormone is important in blocking the stomach motility. Although this hormone works mainly on the gallbladder contraction, also work on gastric motility and inhibit the gastric motility induced by the hormone gastrin. Also another hormone, secretin, and inhibits the gastric emptying. Other hormone is the GIP, or we talked about it last lecture as well. And this hormone main function is to stimulate the secretion of insulin from the pancreas. However, it has general but weak effect on decreasing the gastric motility. And this hormone is stimulated by the presence of fat mainly. However, carbohydrates in the duodenum also stimulate its secretion. Okay, we're done with the gastric motility. Now we'll talk about the small intestinal motility. We have as usual, two types of movement: the mixing or the segmentation, and the other one is the peristalsis or pushing of the food. As we talked briefly last lecture, there is a motility called the segmentation, and this is important for mixing the intestinal content with the secretions, so the digestion process will take place more efficiently and properly. And also always the segmentation will add more to There is segmentation, propulsion. So it's fictitious actually to divide the movements because they both work in the same line. يعني صعب إني أحكي إنه هاي فقط mixing وهاي فقط peristalsis لأنه في overlapping between both kinds of movements. And as usual, always any stretching, presence of food within the intestinal lumen will stimulate these kinds of movements. And the segmentation is caused by localized concentric contractions, and the interval is variable. This will give the appearance of the intestine, the segmented the intestine at different parts, and this will give the chance to mix the chyme. And these waves or these contractions are called by the slow waves, and the frequency is variable depending on the place within the gut. For example, within the jejunum and the jejunum, more frequency of these waves, about 12 waves per minute. Terminal ileum, they are 8 within the terminal ileum. It's important to know that these mixing movements are blocked by atropine, and the myotonic nervous plexuses are important for the formation of these kind of movements. If there is no myotonic nervous plexuses, no mixing movements within the small intestine. The other kind of motility is the peristalsis, and these kind they are weak propulsive movements, and they die within like 3 to 5 minutes, and they are stimulated by chyme in the small intestine or distension of the stomach through gastroenteric reflex, which is mediated by mentoric nervous plus. It's important to know that these are slow and weak contractions, and it's important actually to be slow and weak to make the digestion process and absorption as much efficient as possible. And this push the chyme into toward the ileocecal valve, also exposing more chyme to the mucosa for the purpose of absorption. The velocity is about 0.5 to 2 centimeters per second, and it's faster in the proximal intestine than the terminal ones. And the time taken for evacuation of the chyme from the stomach pylorus to the ileocecal valve is about 3 to 5 hours. Now, when the chyme reaches the ileocecal valve, there is like a relaxation or a block process where the chyme stay for a longer time there. Once the human have another meal, there will be gastroileal reflex. Gastroileal reflex. Gastro from the stomach to the ileum. The stomach asking the ileum to increase its peristalsis and to push the chyme toward the colon. There is a kind of peristaltic rush, which means increasing the frequency and the speed of peristalsis. That this happens, there is irritation of the intestinal mucosa, for example, in case of infectious diarrhea, and this will result in more powerful and rapid peristalsis. These are initiated by nervous reflexes from the autonomic nervous system and the brainstem, increasing the myotonic nervous plexuses reflexes. So this will result in a quick peristalsis movements that will wash the content toward the colon, so relieving the irritation of the mucosa. The motility of the small intestine is also regulated by hormonal factors, which we talked about before. For example, the gastrin, insulin, cholecystokinin, motilin, and serotonin increase the intestinal peristalsis. On the other hand, the secretin and glucagon will decrease the intestinal peristalsis. Just a few words about the muscularis mucosa. I think we talked about this in the last lecture, and this muscle is really important because it works on the folding of the intestinal mucosa. And folding will increase the surface area and increase absorption within the small intestine. Also, contractions of fibers of these muscles will result in the contraction of the intestinal villi, and this will results in lymph clearance from the central lacteals to the circulation. These contractions is regulated by the submucosal nerve plexus. It's important to know that they are regulated by the submucosal, not the mesenteric nerve plexuses, in response to the digestive substances within the small intestine. Now, at the ileocecal junctions, في عنا two mechanisms, the valve and the sphincter, that regulates the movement of the intestinal material from the small intestine to the large intestine. The valvular function is important to prevent the food backward movement to the intestine, while the sphincter function is important for the emptying of the small intestinal content to the cecum. Usually, every day there is about 1.5 to 2 liters of chyme pushed from the small intestine to the colon, and this process needs to be regulated, and it's mainly regulated by the enteric nervous system and the prevertebral sympathetic ganglia. It's important to know which factors that increase the intestinal emptying, which one inhibit the movement of the chyme into the large intestine. For example, any pressure or irritation within the ileum would result in opening and relaxation of the ileocecal valve, so the irritation or the distension will be eased and washed to the large intestine. Also, the fluidity of the chyme, more fluid, more passage of chyme from the small intestine to the large one. It's important if there is any pressure or irritation on the other side of the valve, which means inside the cecum itself. This would result in inhibiting the peristalsis. So less food or less chyme is coming from the small intestine, and this will result in a more contraction of the ileocecal valve sphincter muscle. For example, if there is any appendicitis, which means inflammation of the appendix here, the part of the colon, this would result in emptying of the small intestinal content into the large intestine. The last part of this lecture is talking about the motility of the colon or the large intestine. Now, the colon function, it has two functions. The first one is absorptive, and it's located within the first proximal half of the colon, and within the distal half is for fecal material storage. And this shows the texture of the fecal material or the food substances within the colon, starting fluid here at the proximal part of the colon and going into semi-solid and solid material within the distal half. It's important to know that increased motility means less absorption, more loose stool or diarrhea. On the other hand, less motility means more exposure of the colon material into the mucosa, so more absorption and less, so more hard fecal materials, or even this will result in constipation. It's important to know that the colon doesn't need to be as active as the small intestine, so the movement is minimal or sluggish within the colon, and has as the other part of the gut mixing and propulsive movements. The mixing movements, are called haustrations, are caused by contractions of the circular muscle and the longitudinal muscles, which are called the tinea coli of the colon at the same time, and this will result in bulging of the colonic structures, causing the appearance of haustration. So this is a clearing more bulges or sacs. They are caused by combined contraction of the circular muscle and the transverse muscles of the colon. And this is important for the mixing, and also it will push the fecal matter downward. The haustration is important for electrolyte and fluid absorption within the colon. And as I said, it pushes the fecal material down the colon, and it takes about 8 to 15 hours to remove the chyme from the ileocecal valve downward to the anus. Now, other kind of movement is the propulsive or mass movement. It's important to know the mechanism of these kind of movements because this is mainly involved in evacuation of the fecal material within the colon, and there is about 80 to 100 ml of fecal material per day. And these movements starting from the cecum downward to the sigmoid colon to initiate the evacuation of the colon, and it takes about 1 to 3 times per day, and it's mostly active in the morning. Well, the mechanism of the mass movement means there is a large part of the colon will contract as a single unit to evacuate the colonic material. And there is distension here within the colon, so there will be a constriction or constrictive contracting ring here. This will result in loosening of haustration of the colon distal to this area. So no haustration, and this will result in contraction of all this unit as once. So this more efficient in pushing the fecal material downward. And this contraction usually happens continue for like 10 to 30 minutes every day, and they return back like after 12 hours. These movements are initiated by duodenocolic reflexes, which are mediated by the autonomic nervous system and is stimulated by distension of the stomach and duodenum. So distension of the stomach and duodenum, distension up there will tell the colon, please empty your content. We have more coming, so you can deal with them. Now, the defecation reflex. هذا مهم معنا شباب صبايا تعرفوا تفهموا الميكانيزم والتكنيك. Most of the time the rectum is empty, and this is caused by 2 factors. The weak functional sphincter between the sigmoid colon and the rectum, and also the sharp angulation at this area. So most of the time rectum is empty. Once the fecal material reach the rectum through the mass movement, there is a desire for defecation. So the defecation reflex will start, and the rectum will contract, and there will be relaxation of the sphincters. You know, there are 2 types of sphincters at the anus. The internal anal sphincter, and it is a thickening of the circular smooth muscle in the anus, and it is surrounded by external anal sphincter, which is a kind of voluntary muscle. It's a voluntary muscle. The external anal sphincter is innervated by the pudendal nerve, the somatic nervous system, and it is under voluntary, conscious, or at least subconscious control. It's always contracted unless there is voluntary relaxation of this muscle. This would result in a defecation process. There are 3 levels of control for the defecation process: the intrinsic one, the parasympathetic, and higher center involvement. Intrinsic reflexes is mediated by the enteric nervous system of the gut. It's a kind of weak reflex. However, it's enough. It's a weak reflex, but it is enough. If there is no extrinsic stimulation or extrinsic supply, the intrinsic autonomic nervous system is enough to create the defecation process. And this is stimulated by the presence of feces within the rectum through the mass movement. Now, how is the reflex initiated? The feces inside the rectum. This will result in a distension of the rectum. This will go in afferent signals through nerve plexuses to the through the myenteric nerve. This is local. Will stay within the gut itself. This will result in stimulation of peristalsis in the descending and sigmoid colon plus the rectum, and this will result in pushing the feces toward the anus the internal anal sphincter, which is under involuntary control, will be relaxed. So the internal anal sphincter will be relaxed. However, if the external anal sphincter is voluntarily relaxed, the defecation process will happen. If the external anal sphincter is not voluntarily relaxed, so the feces will stay within the rectal area, and the sensation of defecation will persist for a while, then it will disappear. So it's important for the person to keep his bowel habit. Now, the parasympathetic reflex intensify or support the intrinsic reflex, make it more stronger, more efficient in the process of evacuation. And this happens when the nerve endings within the rectum are stimulated. See, this picture is better. When the nerve endings within the rectum are stimulated, they go into afferent nerve fibers to the spinal cord. So the spinal cord is important in the parasympathetic stimulation. And this will go through parasympathetic, through the pelvic nerves to most part of the colon, resulting in peristalsis, relaxation of the internal anal sphincter, and if the external anal sphincter is voluntarily relaxed, it will result in the defecation process. Now, in addition to these movements, contractions within the rectum itself, relaxation of the sphincters, there is another kind of movements that takes place through the spinal cord reflex. These are including deep breath, closure of the glottis, contraction of the abdominal wall muscles, increased intra-abdominal pressure, plus pelvic floor relaxation for the defecation process to take place. Okay, it's important to know that in the newborn babies and people with transected or spinal cord injury, these reflexes is not working and will be automatic emptying of the feces. It won't be under voluntary control. Now, this cord defecation reflex also can be excited either digitally or with enema, so to stimulate the process of defecation. في عنا last some reflexes that affect the gastrointestinal activity. The first one is called peritoneal-intestinal reflex, and this is caused by irritation of the peritoneum. يصير في عنا peritonitis or inflammation within the peritoneum. This is very strong stimulus and will result in intestinal paralysis. مهم شباب صبايا بعدين بالجراحة راح تتواجهوا هاي الأمور، إنه بيكون في عندك intense inflammation with the peritoneum، ما في no bowel sounds، ما بتسمع bowel sounds لأنه الintestine are already paralyzed. Other reflexes such as in renal-intestinal reflex, there is irritation of the kidney. هذا بالمرضى الrenal colic بصير عندهم. Inhibiting the intestinal activity. Also, vesico-intestinal reflex, so there is of the urinary bladder, resulting in inhibiting of intestinal activity. So that's it for our lecture today. الله يعطيكم العافية. في حد عنده أي سؤال؟ حد عنده سؤال؟
دكتور
تفضل.
هلا سؤال، ايش الفرق بين البايلوريك بامب والبايلوريك سفنكتر ولا نفسه؟
لا، البايلوريك pump it is the process, the mechanism by which the food is pushed, يعني mediated by the peristalsis. So the action movement of the peristalsis within the stomach to push the food through the sphincter is called pyloric pump. So it's referring to the motility rather than a structure within the stomach itself.
تمام دكتورة, thank you.
يا هلا. حد عنده أسئلة ثانية شباب صبايا؟
يعطيك العافية دكتورة.
تفضل.
دكتورة, بالنسبة للمحاضرات بعدين لما نيجي نراجعها، ايش الاشي ندرسه احسن اشي؟ ندرس من كلامك والسلايدات ولا نرجع للكتاب ندور فيه مرة ثانية؟
شوف يا أحمد، أنا حكيت هذا الحكي بالمحاضرة الماضية إذا حضرت. المحاضرات والشرح بيخليك في البريتونيوم، لكن هذا لا يغنيك إنه أنت مثلا إذا بتحب تتوسع بموضوع